50 milliliters. The physiological dead airspace is the anatomical dead airspace plus a variable, however many non-functioning alveoli you have. The only reason that's in there is because if you have a lung disease that increases the number of non-functional alveoli, this can become a factor to somebody. Perhaps not to us, but to somebody. Tidal volume. The amount of air moved. Actually, I'm not being accurate. It's the amount of gas is what they're talking about, but hopefully that gas is air. I say air because we're talking now about healthy lungs. The amount of air moved in a normal breath, about 500 to 600 milliliters. What goes in, what goes out normally, the tidal volume. The inspiratory reserve volume is the amount of air that can be forcefully inspired. That's the inspiratory reserve volume, the amount of air that can be forcefully inspired, usually about 2,000 to 3,000 milliliters. The expiratory reserve volume is the amount of air that can be forcefully exhaled. It will be less, usually about 1,200 milliliters. The residual volume. Residual volume is the amount of air that remains after the expiratory reserve has been evacuated. That is the residual volume, usually about 1,000 to 1,200 milliliters. Speaking of pulmonary capacities, if you missed the definition of a pulmonary capacity, it's the sum of two or more of the pulmonary volumes we just talked about. So when you start putting them together in different combinations, you've got pulmonary capacities. The inspiratory capacity is the tidal volume plus the inspiratory reserve. The tidal volume plus the inspiratory reserve is the inspiratory capacity. It's the normal amount a person can forcefully inspire after normal expiration. Usually it's going to be about 3,500 milliliters. The second pulmonary capacity we talked about is the functional residual capacity. This is the expiratory reserve plus the residual volume. And that one again is the functional residual capacity. Expiratory reserve plus the residual volume. The amount of air remaining in the lungs at the end of a normal expiration. Sound like it is. About 2,300 milliliters. The third, and what I said probably one you may hear again, is the vital capacity. This is the amount of air moved on deepest inspiration and expiration. The vital capacity, the amount of air moved on deepest inspiration, expiration. This is the inspiratory reserve volume plus the tidal volume plus the expiratory reserve volume. Once again, the inspiratory reserve volume plus the tidal volume plus the expiratory reserve volume. And it is approximately 4,600 milliliters. Total lung capacity. This is the inspiratory reserve plus the expiratory reserve volume plus the tidal volume plus the residual volume. Again, the total lung capacity is the inspiratory reserve plus the expiratory reserve volume, the tidal volume, and the residual volume. It's about 5,800 milliliters. This is the granddaddy of all of them, the sum total. I gave you two rates, minute volume, which is simply the tidal volume times the respiratory rate times 1 minute. In 1 minute, excuse me, not times 1 minute, in 1 minute. And the minute alveolar ventilation, tidal volume minus the dead space times the respiratory rate. Now for the benefit anybody missed those, I went over them again. Now, we have a few more structures that we're going to touch on very basically. Well, somebody shut that back door. I don't know why, but it seems like I get more noise when that door is open. Thank you, partner. All right. The thoracic cavity itself, we can think of it as basically a pressure chamber. Changes in the pressure inside the thoracic cavity is what stimulates us to breathe in and breathe out. The diaphragm and to a lesser degree the intercostal muscles, we'll talk a little bit about those, but mostly it's the diaphragm is stimulated. The pressure inside the thoracic cavity when the diaphragm is stimulated and pulls downward is less. Pressure inside the thoracic cavity is less than that of the outside atmosphere, therefore air moves in. Expiration is a passive process. What's the matter? Excuse me?
Got a little fast there.
Okay, I'm back up. Thank you for telling me. We look at the thoracic cavity. This is my little crude thoracic cavity with a diaphragm. And it should be not closed, but there should only be a way in. As a pressure chamber. The lungs, we don't even have to think about the lungs. Just think about the pressure chamber right now. The diaphragm contracts and moves downward. Now this is it's not a sealed chamber, but we only have one way air goes in. When it moves downward, it changes the pressure in here. The pressure inside that cavity is now, when this moves down, less than the pressure of the outside air, the atmospheric pressure. When that happens, air is pulled in, and that will continue, oddly enough, not until it's equalized. Some people I know, I'm looking at them, and they're thinking about gradients, and they're thinking, oh, it'll pull the air in until it gets equal. No, it won't. It'll pull the air in until the lungs are stimulated to stop pulling air in, and we'll talk about that in just a minute. But it will pull air in. As the diaphragm is stimulated and pulls down, it pulls air in because pressure in here gets lower than the outside air. Exhalation normally is a passive process. What happens is the diaphragm stops stimulating to contract, so it relaxes. Diaphragm is made of skeletal muscle. Skeletal muscles stimulated by direct innervation. It's a word you may not have heard, innervation, which basically just means it has nerve contact. If I say something is innervated, it means there are nerves connecting to it. If you'll probably hear me say that word a lot. It was thrown at me a lot. As the diaphragm relaxes and moves back into its original position, the pressure in here goes up. And as long as air has a way of going out, it's going to go out. At the end of exhalation, theoretically, at the end of exhalation, the air in the thoracic cavity is nearly equal to the air outside the thoracic cavity. I put that in there for a very special reason, because I know for a fact I saw it on a test once. At the end of exhalation, the air inside the thoracic cavity or in the lungs is going to be nearly equal to that of outside air. For the purposes of this class, we need to know that the diaphragm is not the only muscle that aids in respiration. The intercostal muscles aid that as well. These are the muscles that actually lift the rib cage and give the lungs a little more room to expand, the intercostal muscles. One of the things that we can possibly see out in the field that is not a good sign at all is intercostal retraction, especially upon further investigation when you find out that that's the only respiratory muscles that are working. The diaphragm's either been ruptured or for whatever reason it's not the main muscle. Without the diaphragm, the better part of our respiratory effort is gone. The intercostal muscles have a hard time doing it on their own. As a matter of fact, if you've got someone, and I'll go ahead and say this, we're not actually into the respiratory emergency part, but if you've got someone, or you can watch those intercostals working, you've got a pretty severely distressed patient. Children, I don't want to get too far ahead of myself, but children, it's much more common to see intercostal movement for some reason, and some of you may know better than I what that is. It's not as grave a sign to see intercostal movement or a lot of intercostal work in a child. You see it in an adult, it's pretty grave. All right, let's talk about the neurogenic control. We've talked about the structures. We've talked about the machine. Let's talk about what controls the machine. The neurogenic control. First of all, the respiratory center is in the medulla of the brain. The medulla, as we know, controls vegetative functions. These are the most primitive of functions, and this is what the medulla does. Vegetative functions, digestion. To a limited degree, cardiac function. The heart is a funny muscle. It doesn't necessarily need the medulla telling it to beat. What the medulla tends to do is tell it how fast to beat and when to slow down. The heart, as we know, has the characteristic of automaticity, making it the only muscle in the body that does. It can generate its own impulse. That's why so frequently we find people who are checking out, who've stopped breathing, but they still have a pulse, that annoying characteristic. They're dead, and the brain doesn't know it, or the heart doesn't know it. The brain knows it. It's already shut down the respirations. But the heart doesn't know it because it doesn't need anybody to tell it to beat. Another thing that I want you to know is that I don't want to get into specifics as far as, it's not necessary, but I do want you to know that the respiratory center sits low on the medulla. And you say, why in the world, Robbie, is that important? It's important when intracranial pressure increases from hypoxia or from a bleed into the brain. There's only one little hole in your skull, guys, called the foramen magnum. It's the hole that the spinal column comes out of the brain, off the medulla. Just above that opening is where the respiratory center is. If that brain stem pushes through that hole, or as we say, herniates. If you ever heard of a herniated brain stem? One of the first things that usually you're going to see is either a total wiping out of the respiratory effort or at least some really bizarre respiratory patterns. Now, when we get into the actual respiratory emergency part and get off anatomy here, we'll talk more about that. We're going to talk about different respiratory patterns and what they may mean to you in an assessment. But I do want you to know where. I want you to know that it doesn't take a lot, since there's nowhere for that brain to go when it starts to swell up or when blood is introduced in there that has nowhere to go. It pushes the brain down and pushes the brain stem through that little hole. And usually, I had a patient I remember that I could tell you the moment it happened. Guy was a bad CVA patient, obviously big CVA. We walked through the door. He was breathing irregularly, but he was breathing, and then he stopped. And I know for a fact what happened. And we just happened to witness the herniation of his brainstem, and that was it. Brain is an unforgiving organ. Many of the organs in the body are very forgiving. Liver, for example, we abuse that thing all our lives. And yet, it takes a lot to kill it. The brain is not a very forgiving organ. Brain tissues do not reproduce. If you kill brain cells, they're gone. That's a point I can't emphasize. When you're treating the CVA patient or the patient that you think maybe have had the CVA, or you're treating a severely hypoxic patient because brain tissue swell as a response of hypoxia, that should be on your mind. That in a moment, they can herniate, and now in addition to a CVA patient, you've got a respiratory arrest patient. And a respiratory arrest patient with a prognosis that's not real good. I don't think I've ever seen anybody return to a productive or even a aware state of mind after they've herniated the brainstem. Have you ever seen one? I've never seen it. They herniate that brainstem, it's pretty much the ball game. All right. The respiratory center, and if you'll notice when you read your text, they'll see it referred to as the inspiratory center. And there's a reason for that. The respiratory center is located in the medulla, and it is by direct innervation that the respiratory center talks to the diaphragm and tells the diaphragm to move. Keep in mind, it's a lesser point, but it's something I put in my notes, so I'll throw it out there to you, that any contraction of muscle requires energy. Why am I talking about? So the diaphragm requires energy. Inspiration requires energy. Expiration doesn't require any. Progressive respiratory illness means that in order to move air effectively, more and more energy is required. Do you remember me telling you, I think it was last class, how the body mobilizes when it's in trouble? And it reaches a peak to the point where it is fully engaged in fighting whatever's killing it, and you add that one more thing, and it collapses. The defenses collapse. People can exhaust themselves trying to breathe. It requires energy. This is very common in children. One of the tenets of PALS is that you need to correct these respiratory problems because a child can exhaust themselves and die because it requires energy. That's why I threw that in there. I kind of glossed over it when I spoke about it, but I did want to get that out there. Absolutely. A very good example. Geriatric patients, advanced age with a lot of illnesses, they can exhaust themselves. So one thing about being in medicine, you're always learning. I always said when you've seen it all, hang it up. If you think you know it all, it's time to hang the uniform up because you're dangerous. You're always learning. And I did not realize that, was it malaria? You know what you die from? If the fever doesn't kill you, you know what I heard that you die from exhaustion. From convulsions that you can't control. It's no real pathological process. The question becomes, will you survive this till it runs its course? And I'm talking about where there is no treatment available. Of course, you're out in the jungle now and you get it. If you're in a medical facility, of course they can treat the convulsions. And they can treat the fever. But you die from exhaustion. I did not know that. I always thought fever, if anything killed you, it was a fever, but it's not. There's convulsions that come afterwards that may last for days. Same principle. You're burning energy and you can't replenish it and you die. It requires energy to breathe, to inspire. The diaphragm is innervated by the phrenic nerves, which originate, and I'll repeat this so don't freak out, from the 3rd, 4th, and 5th cervical spinal nerves. The phrenic nerves, that is spelled P-H-R-E-N-I-C. One of the reasons that we are so careful with potential spinally injured patients is not just because we can paralyze them. If they have a fracture in the cervical spine area and we sever the phrenic nerves, they're not going to breathe anymore. As a matter of fact, that is the idea behind hanging. The idea behind hanging is to fracture C1 and C2, the atlas and the axis. That's what they call those. When they hung people, a proper hanging, they dropped you down, snapped your neck, you didn't feel anything and you didn't breathe anymore. Because you had disconnected the phrenic nerves.
Did they know that?
Yeah, well, they knew it killed them instantly. I don't know if they knew to call it the phrenic nerves. A lot of people have misconceptions about hanging. Do you know Delaware was hanging people up till like 1920? One of the last places to use it after electricity came around. And it was quite a profession in many areas to be a professional hangman. And you had to know how to calculate. You had to know where to put the knot. That knot, you'll notice how they position that. I even read an account of what a proper hanging was supposed to look like. You were supposed to drop so many feet, make a half turn to the left. This was the Hangman's Journal thing. This is what they shot for. But you had to calculate how much the person weighed, how far they needed to drop to break their neck. Because the worst thing that could happen is the rope broke, or it didn't break their neck and they strangled, because that could take several minutes. A lynching is not a hanging. A lynching was just strangling somebody to death. You put a rope around their head and hauled them up, and they kicked there for 5-6 minutes till they died. But the phrenic nerves is what they were shooting for, and that is why, really, I mean, we don't want to paralyze people for sure, but what is the big threat? If you eliminate paralysis as the reason, the big threat is we're going to sever those phrenic nerves, and that's going to be the end of it. This is why I get real touchy about people who can clear C-spines with their eyes. And I see it done all the time. We don't have X-ray vision, and we don't have X-ray machines. What we do have is a mechanism of injury. What we do have is a high index of suspicion that this could have happened. And there are no second chances if you're wrong and they sever those phrenic nerves. It's over. It's history. The intercostal nerves, or the intercostal muscles, are innervated by 11 pairs of intercostal nerves. And this is from the 1st to 11th thoracic spinal nerves. This is in your book. I'll go ahead and tell you anyway. This is what stimulates the intercostal muscles, these 11 pairs of nerves from the 1st to 11th interthoracic or thoracic spinal nerves. Got phrenic nerves out of the way. On either side, you have to understand that the respiratory center is bilateral. If you were looking at a head-on cross-section of the brain, of the medulla, the respiratory center would be on either side. It would be bilateral. Two collections of neurons, the inspiratory and the expiratory center. I'll go ahead and tell you, I'll cut to the chase. First of all, we don't know what makes the expiratory center work, the expiratory center. We don't know. The expiratory center doesn't even come into play until labored respirations. And we don't know why. We do know that when it works in a reciprocal manner with the inspiratory center. The inspiratory center is telling you to breathe in, the expiratory center is telling you to breathe out forcefully. The inspiratory center is what we're going to predominantly talk about. Now, although the respiratory center is in the brain, it is influenced by two areas of the brain, or by one area of the brain, two mechanisms that are from a higher function, the pons area of the brain, which is just above the medulla. Actually, I've actually seen texts even call the pons part of the medulla. That's fine too, have no problem with that. There are two mechanisms in the pons that are connected to the inspiratory center. And we need to understand something. The inspiratory center, that collection of neurons, nerve cells, that's what neurons are. That collection of nerve cells it'll tell you to breathe, it'll stimulate respirations at a regular rate. What these higher functions do is set the speed, the interval. And there are two basically. One is the vagus nerve. Vagus nerve has a hand in a whole lot of things: digestion, cardiac function, and in this case, respiration. Since the inspiratory center of the brain, the inspiration, is pretty much going to constantly send out impulses telling the diaphragm to contract until something acts on it, we need something that tells us when to stop inspiring. And we have two basic mechanisms of doing that. One, as I've said, is the vagus nerve. It's a reflex act called the Herring-Brewer, spelled B-R-E-U. Herring-Brewer reflex, or I won't say act, I've been doing law too long. The Herring-Brewer act, the Herring-Brewer reflex. Some of the vagus nerve fibers connect to little nerve centers around the alveoli those little structures that expand when we breathe. They're called alveolar stretch receptors. And when they stretch to a certain point, they send word to the inspiratory center through the vagus nerve, stop breathing in. That's one of our two mechanisms. Do I need to repeat that? Anybody got that? Vagus nerve to stretch receptors on the alveoli, and that when they stretch to the point they need to, they send word to the inspiratory center, stop breathing. Or not stop breathing, but stop the impulse to inspire. And we have another one also located in the pons called the pneumotaxic center. Pneumotaxic, just in case you need to spell it, I will spell it for you. P-N-E-U-M-O-T-A-X-I-C. Pneumotaxic center. The pneumotaxic center seems to be, we believe it to be a secondary, sort of a backup. It usually only comes into, as far as we know, only comes into operation during labored breathing. The pneumotaxic center has an inhibitory force. It inhibits the inspiration center from sending out that impulse for the diaphragm to contract. Now there is, I don't want to, let me make sure everybody's caught up with me. Everybody with me so far? We've got the vagus nerve and we got the pneumotaxic. Two ways that the brain is regulated, or the medulla is regulated. There is a third. The apneustic center, also in the lower pons, that is pretty much always active. However, oh, now you might need to spell that. I'm sorry. Apneustic. A-P-N-E-U-S-T-I-C. A-P-N-E-U-S-T-I-C. Apneustic. I'm proud of myself. For several years, I just had a real hard time pronouncing that word for some reason. I don't know why. It's pretty much always active, but it's overridden by the other two. So it's a third one, but it's very minor. When we get to the respiratory emergency part, we're going to talk about apneustic respirations, and it's a grave, grave sign if you see that. If the source of the stimulus to breathe is that area alone, we have a problem, Houston. A big problem. Let's see here. I've already told you the expiratory center remains inactive during normal respiration. All right, let's take stock of where we are at this point in time. We've talked about some basic anatomy. We've talked about the machine. We talked about the structures to the point we need to talk about it right now. We've talked a little bit about the mechanical aspects of breathing. And we've talked about the circuitry from the brain to the machine that causes this to happen. But what regulates it? And that's what we need to talk about now. Regulation of the machine. We got the machine, we got the control panel for the machine. Now we got to figure out how it's going to regulate how that machine works. In other words, what's going to talk to the medulla? We know that the medulla is going to talk to the machine, and we're going to talk about what's going to talk to the medulla. We're going to talk about something called chemoreceptors and to a lesser degree baroreceptors. Chemoreceptors. Oh man, lose it.
Medulla and the medulla, they're the same thing.
Same thing. You can say medulla. I have no problem with that. I don't know where I picked up medulla. Well, I guess that's what it was said to me. Anybody else lost by that? Were you looking for a structure, couldn't find it? So what a little medulla. The medulla, same thing. I should have wrote that one on the board. You can see the spellings are the same. Chemoreceptors monitor a lot of things, but for our purposes today, we're going to talk about that they monitor waste in the blood. Waste products. Carbon dioxide. We haven't talked about partial pressures yet, but we're going to here in just a few minutes because we're going to have to talk about gas exchange. If you're talking about the partial pressures, waste products expressed as partial pressures, carbon dioxide is PCO2. If you don't understand that completely, don't worry, because in the next section we're going to discuss that in depth, okay? But it monitors waste. And what it does, when it monitors an increase in waste above what the body has set it to be standards, it talks to the medulla and tells it to pick up respirations to get rid of it. That may surprise you, and it may not. We do not breathe because we need oxygen, although we do. The main stimulus to breathe in a healthy individual is the chemoreceptors monitoring a rise in waste. And this happens all the time because metabolism is going on all the time. Now, the baroreceptors, these are located, I'll tell you where they are, in the aortic arch. In other words, the largest artery in the body, when it comes up and loops over and heads back down, here you'll find a branch of neurons or nerve cells called the baroreceptors. And they're also located in the carotid sinuses. If you're familiar at all with paramedic procedures for dealing with supraventricular tachycardias, you've heard of carotid massage. This is why we do it. Stimulate the baroreceptors to try to bring the rate down. Try to get the vagus nerve working on our side. Incidentally, some of you may have had different experiences. I have never broke supraventricular tachycardia for any functional length of time with carotid massage. It'd slow it down and it'd jump right back up there again. It just never worked for very long. Now, I've heard other medics tell different stories, that they have had it work for them. I just never have. If the chemoreceptors in the respiratory center fail, or theoretically, and I'm going to tell you why I'm saying theoretically in a moment, theoretically, if they have become dulled because of chronic waste buildup or a patient having a disease which makes it hard to get rid of waste products like emphysema, then the baroreceptors will stimulate the need to breathe due to a lack of oxygen or the hypoxic drive. Now, you must know, if you don't know by now, you should know, this has been challenged by research, and what the verdict's going to be, we do not know. I can tell you that in the old days, even in my early training days, when I was being trained, they used to tell us to take a hypoxic patient, start them, if they had emphysema, if they had any COPD illness, start them on low O2 and move up, because we were afraid of knocking out the hypoxic drive. And they come to find out that happens maybe 1 in 1,000 times. It's just not worth withholding oxygen from a hypoxic patient. One of the rules for oxygen administration, never withhold oxygen from a hypoxic patient. Yes?
You know, that's hard to tell some people from the old school.
There are some old timers that'll fight you over it.
You go into a house with a COPD patient, they're on 2 liters, and the home nurse is standing there going, what's wrong?
Absolutely.
You throw them on the back of the truck, you got somebody that's been in the squad for 20 years.
Yep.
They want to fish, want to complain. Let's put them on 3.
Yep.
I say put them on 15 and flow it to them.
Absolutely.
Dr. Marsh told us it's going to take an hour to effect. By that time, you're going to
Sure.
have them in the hospital. It's going to be their response.
1,000 to 1 are good odds. I'm willing to play that. If it's 1 in 1,000, I'll take those odds. And if you think about it, hypoxia, people are dying. And if you think, and there's even a better reason than that. Number one, most of your emphysema patients know they have the illness. Most of them live with it every day. If they've called me, something bad is wrong. Something has changed radically. And I'm not going to dick around with that, frankly. I mean, but you're right. Old-time medics, EMTs, nurses, they'll steal. I've actually even been questioned as why I had a non-rebreather on somebody in the ER with emphysema. And had to have my medical director go back to this person and say, you're about 20 years out of date. You know, these people are taught never to withhold oxygen to a hypoxic patient. How many of you remember a device called the Venturi mask? That was when that thing was created for us anyway. Venturi mask was a mask that you could dial in the amount of oxygen you wanted to deliver. From, gosh, what was it? 30%, 33% up to 60. I think it is outside. I hadn't seen one in years. But that was the reason, one of the reasons that that thing was developed. Then somebody come up and realized that, look, the O2 flow is not the problem. Getting to tolerate a mask is the problem. So the Venturi mask kind of got tossed by the wayside, and we don't use it too much anymore. Some people may still be carrying it, but I don't know of anybody. Just as a rule, there are very few things that we carve in stone, and that's one that we do. Never withhold oxygen from a hypoxic patient, regardless of the history. Never. As paramedics, and even as intermediates, they stop breathing, fine. Tube them. I can probably give them a lot more air than they're getting on their own anyway. And that's why I got all that fun equipment to play with. They stop breathing, I can fix that too. All right. I don't know that we're going to get through gas exchange tonight. The hypoxic drive theory has been challenged. I do not know what the final verdict. If you want to know the truth, guys, the mask suit has been challenged, but they've never made a verdict on it. Every physician has their own feeling about masks. All I can tell you is I've seen it work. That's all I can tell you. Whether, you know, there's a lot, it's counterproductive, this, that, it may well be, but I have seen patients with systolic blood pressures of 50 go up to systolic blood pressures of 85 and 90 after we put them on. So you're going to have a hard time convincing me that they're not good for something. But we'll go with whatever the prevailing winds say. Has anybody heard anything new on those in the last 5 years?
About 10 years ago, they were real popular.
Oh, yeah.
They all had them, but now...
Anybody using them?
We got them on our truck.
Yep. We had them on ours. We never used them. Anybody using them? They can also be very dangerous if people around you don't know how to deal with them. Yeah. Quick story about mask trousers. We had a patient we took from Annie Penn Hospital to one of the local trauma centers, and it was a trauma patient. We had them on the mask suit, inflated, fully inflated with the large bore IVs and all this. Patient was bad enough that the ER physician at Annie Penn had called the hospital, and they informed us to take this person directly, which is rarely ever done, or at least not where I came from, directly up to the OR suite, directly to the door. They met us at the door, took our stretcher and all. Said they'll, you know, as soon as they get him prepped and get him over on their stuff, they'll send our stuff back out. Well, I was going back down the hall, and we were going out to clean up our truck and get ready to roll, and all of a sudden, it wasn't probably, I know it couldn't have been 10 minutes, we hear them give their code blue alarm. I didn't immediately recognize, because they didn't say OR, they said something else, and I can't remember what it was. Somebody coded. Thought it was odd. Not that somebody coded, but that they coded in that area or in that area. Well, I didn't think anything about it, and they kept our stuff in there for the longest time. But when I finally got back up there to get it, they had rolled our stuff back out, and laying on that stretcher was my fully inflated set of mask trousers. And suddenly the reason for the code became, at least in my mind, pretty apparent. They took him in there and got ready to prep him for surgery and yanked him things off. And he crashed. At least that's what I think happened. In any event, I should not have gotten back an inflated pair of mask trousers. Unless he died before they took him off from something else. But I can tell you he rode 60 miles and stayed perfectly stable. And then we got him in there, and that's what I think happened. I don't know. But I know myself, I've been in ERs and had to get between some person in that ER with a pair of scissors and a mask suit. You're not cutting them things. Well, I want them off now. And you have to explain to them there is no off now. We can get them off in 2 hours maybe, if we start now. 3 hours, but there's no getting these things off now. Once they're on, they're on. So, I don't know, you know, I have had to do it. Don't you even think about cutting those things off. And get your hands away from that Velcro. Anyway, gas exchange. I don't know, I really don't remember when I taught intermediate last how in depth we went into gas exchange. And we're not going to go that in depth with it now. We need to understand a couple of things. Some of you in here may have taken physics, some of you may have taken chemistry, some of you may have advanced sciences, and they may help you, probably will help you. You don't need to be a rocket science to understand enough about physics and chemistry to understand gas exchange, or at least why it happens. We need to talk about something called gradients. Gradient is a direction of flow. A direction of flow, for our purposes, is a direction of flow from an area of high concentration of something to an area of lower concentration of something. And if we went and gave the physics definition, we would say it travels from an area of high concentration to an area of low concentration until an equilibrium is reached. It's just one of the forces of nature that it happens. And there are all kinds of gradients. For example, this room is not an outside room. In other words, we're not attached to an outside wall. But let's say we were, and this is not a good night to use this example. But let's say it was 30 degrees outside, and it's 70 degrees in here. What's separating the concentration of air in this room at 70 degrees and what's separating the concentration of air that's 30 degrees is that wall. Now, we're not talking about insulation characteristics here, but the principle is this. This high concentration of warm air will try to flow toward the low concentration of warm air. And it will, in fact, do it, because the wall will absorb it and pass it on through. And that will continue to happen until the air in this room is the same temperature as the air outside, because there's not enough room, not enough warm air in here to warm up the outside to an equilibrium is reached. It'll continue until the temperature on both sides of the wall is the same. It's called a temperature gradient. You can flip that around if you want. We could say there's a high concentration of cold air outside that wall and a low concentration of cold air in this room. So that cold air is going to continue to flow into this room until it is just as cold in here as it is out there. An equilibrium has been reached. You know, it's not going to keep flowing in here till it's 10 degrees in here and 30 out there. It doesn't work that way. It'll only flow until it's equal. We have an equilibrium. We can say, and keep it very basic, and we can say substances, whether they be animal, vegetable, mineral, substances, matter, gas of like kind, of the same kind, will follow this pattern. If you have a high concentration of one and a low concentration of other, the high concentration is going to move toward the low concentration until they are equal. Has everybody followed me so far about gradients? So if we have a high concentration here and a low concentration here, the high concentration is going to move toward the low concentration until what? Till an equilibrium is reached. It's a very, very important principle and a very, very important law of nature. If it weren't for this, we would not be alive. We could not live. And I'm going to explain why. Diffusion. Another thing we need to understand. Gradients and diffusion. Diffusion is the spontaneous movement of gases when a gradient is present. So in essence, diffusion is nothing more than a gradient that is gas. We're talking about gases specifically. A while ago I used the example of a temperature gradient. We're talking about gases now. You have two gases of like kind that have different concentrations. By the process of diffusion, the area of high concentration will move toward the area of low concentration until an equilibrium is reached. That is diffusion. Everybody clear on that? Because we're building the foundation for gas exchange, and I'm running out of time. We'll probably have to continue this next time. Let's see what I can get in here. All right, I'm going to try to finish just a couple of things, and we're going to call it a night. Because everybody's brain is probably about full, and our hands are tired anyway. Composition of air. Air is not oxygen, although it has oxygen in it. As we know from basic CPR, what is the percentage of oxygen in our atmosphere? 21%. It's about 78% nitrogen. And we have various trace gases that make up about 1%. And we all know that depending on where you are, you'll pick up higher trace gases and things of that nature. But 21% of what we breathe, which is air, is oxygen, which is what we need. We don't have very much use for nitrogen. Got a lot of it in the atmosphere, but we don't have much use for it. But we do need the oxygen. This is where partial pressures comes in. Atmospheric pressure at sea level has a total pressure of 750 milligrams of mercury, which is expressed as mm big Hg, millimeters of mercury. Atmospheric pressure is the total of all of those gases, nitrogen, oxygen, and those trace gases. 760 millimeters of mercury. If oxygen makes up 21% of that, well, actually, I should say this. Let me get this out of the way. Let me write a couple of things right quick. 760 millimeters of mercury, total atmosphere. This could also be expressed as 760 torr, T-O-R-R. Don't ask me what it means. I have no earthly idea. It's just another way. It's the same thing as a millimeter of mercury. 1 torr is 1 millimeter of mercury. Sometimes you'll see it expressed that way. That's why I want you to know about it. You might see instead of 760 millimeters of mercury, you might see 760 torr. If oxygen composes 21% of 760, then we can, I'm not going to make you do the math. We can express the partial pressure. This is total pressure. This is the total pressure. What we want to find out is what is the oxygen component of that? What is the pressure of just that? It's not since it's not the total pressure, it is a partial pressure. Everybody with me? We're not talking about the whole pressure. We're just talking about the slice of the cake that is composed of oxygen, otherwise known as a partial pressure. Partial pressure. If oxygen makes up 21% of the whole, then we can express it as a partial pressure of 160 torr, or millimeters of mercury. 160 would be the partial pressure of oxygen, or partial pressure of O2 equals 160. Everybody with me? It's not really that complicated. When we start talking about total pressures, and we want to break the total pressure down into its component parts and figure out what value it has, then we know that oxygen is 21% of this big hunk, so we just do the math. 21% of 760. should be 160 torr. Partial pressure of that, we can say 160 is the partial pressure of oxygen in our atmosphere, expressed as PO2. Sometimes you might see PaO2. Big P, little a, O2. Anytime you see that, we're dealing with partial pressures. Questions? You look like you got a question around the tip of your tongue. You don't? You with me? Everybody with me? Then let's quit while we're ahead. Any questions about anything else? Bear with me on the test. We don't have that much more to go. We're going to pick up here next time, and we're going to talk about gas exchange, and then we'll go into some other respiratory.